account, then open account, and then because he cannot use his computer.
No, he can.
Assalamu alaikum. Good morning. First, let me introduce myself. My name is Tamer Awad. I'm from Ozeka Medical, a German company based in Berlin. We produce external pacemaker for post-cardiac surgery, and we developed a new technology for measuring cardiac output, totally non-invasive, and its name is electrical cardiometry. So our presentation today, we will talk about hemodynamic monitoring using electrical cardiometry, our technology. So what do we mean by hemodynamic monitoring? Hemodynamics, from our point of view, is a part of cardiovascular physiology dealing with all forces affecting blood flow and blood pressure. So anything affects blood flow and blood pressure, we try to monitor. The global aim is to monitor or to help you to give the patient, or the patient can have adequate supply of oxygen to all tissues. For you to do the hemodynamic monitoring, you used to measure a lot of things like ECG, blood pressure, SpO2, hemoglobin. Clinically, you can look to the urine output and the lab results, and even using echo to assess the patient hemodynamics. But all these techniques couldn't answer some questions, some challenges, like fluid management. Which type of volume to give, when to stop. This is an area that everyone is talking about now. Also compensating shock. Can we predict shock early? And this is actually, I'll show you one example, happened in one of the surgeries I attended, and we will discuss it together. So, early prediction of septicemia. This is more in ICU, not in the OR, but however, I attended 2 cases with patients for re-exposure with septicemia in OR. So, volume positive inotrope or vasoactive drug. This is a classical debate in ICU more, but you can face it in OR. When to wean, when to stop the positive inotrope. Do the patient has an overdose of positive inotrope? This is something new. And patient response for treatment. What is the effect of the drugs that we give to the patient, which is different from patient to another? For that, we measure some parameters that can indicate preload, like stroke volume variation. Everyone is talking about it now in a lot of literature. Corrected flow time for if the patient is not spontaneous, mechanically ventilated. A contractility indicator, and afterload, vascular resistance, and thoracic fluid for the whole chest fluid, especially pulmonary edema. If we can have all these parameters together, it can aid your decision in terms of which drug needed and patient response. Usually, your classic monitoring can show you this picture. You try to handle the oxygen delivery using hemoglobin, SpO2, heart rate, and blood pressure, and some clinical and neuro expertise. But the real picture is like this. Having an online monitor that can give you a beat-to-beat indicators of all these things together, it can aid your decision. It can help you. That's why it's our technology. We are developed from a classical technique. Its name is bioimpedance. Bioimpedance was discovered or developed by NASA early 70s. They discovered that when they pass a high frequency current in the thorax, so the outer electrodes, they emit current, they give current to the patient, and the inner electrodes, they are measuring electrodes. So measuring the change in the same frequency, it will show us such curve. Removing the respiration effect, we will see that there is a change after each QRS. Then they try to analyze why this change happens, and this is synchronized with the ECG. So it passed by a lot of versions. Actually, the early version stopped now from the market. It was the last version. It was like last 80s developed. Yes, 80s. And now our technology is the latest. We can call it the third generation of bioimpedance. But all the bioimpedance said that there is a DC shift or static shift for this curve. This static shift, we call it thoracic fluid content. So the amount of volume between the two electrodes is this distance. If the amount of fluid within the thorax is high, because of pulmonary edema, because of severe chest infection, this distance will be shortened, will be very low because of high fluid. If the chest is dry, this distance will be higher. So this static shift, we call it thoracic fluid. Is it correct? There was a technical review done by the critical care assessing all the methods quantifying pulmonary edema in patients. And they was talking about the gold standard MRI at this time and chest CT. And later, lung ultrasound water index became one of the gold standards. But in the technical review, they talk about the bioimpedance. And they said that bioimpedance is highly sensitive. So any degree of fluid overload, it will show you an increase in thoracic fluid. So the trend of the thoracic fluid is very important. However, it's very sensitive, it's not specific, because the bioimpedance does not quantify pulmonary edema, according to this technical review. Actually, bioimpedance, they look to the amount of fluid between the two measuring electrodes. So anything. So intrapulmonary, intravascular, interstitial, intracellular, all together. So that's why it's very sensitive. It can give an early prediction of fluid overload. It can give an early prediction of developing congestion. These all you can see during the surgery. So our technology say that the change in bioimpedance is due to reorientation of RBCs. RBCs, because of the turbulent flow while the aortic valve is closed in the ascending aorta, RBCs are in random orientation. So the resistance here is high. Once the aortic valve opens, the flow is laminar, RBCs are reoriented in the flow direction, and the resistance changes. So this causes the change in bioimpedance. So the first thing, from this curve, actually this is a division of this curve over time. So from this curve we can detect the point of aortic valve opening and the point of aortic valve closure. And you can see this triangle looks like the VTI measured by the echo. So area under the curve is equal to or equivalent or in direct correlation with stroke volume. And this is how we measure stroke volume. So we detect the point of aortic valve opening and the point of aortic valve closure. So what do we measure? The first thing that we measure is the point of aortic valve opening and closure, and we can get the left ventricular ejection time, the aortic valve opening time. And then we measure this very small time, which is isovolumetric contraction time. In cardiac surgery, it can help because it can show the doctor if the aortic valve problem, conduction problem, all these can prolong this time. So So isovolumetric contraction time, area under curve, we measure stroke volume, multiplied by heart rate, we can get the cardiac output. Then we said that this change is due to the reorientation of RBCs. In terms of math, this change is due to velocity. So this velocity over time gives us the acceleration. So the distance from here to there is the peak aortic acceleration. And it's a good indicator of contractility. But is this valid? There was a textbook, its name is Hemodynamic Monitoring, using echocardiography in critically ill. And the author, Daniel De Baker, said that it was clinically proven that peak aortic acceleration is a good indicator of contractility and less affected by preload. However, this index is not commonly used because it is affected by afterload. So my monitor can show you the afterload and the peak aortic acceleration together. So you can do the differential diagnosis. Is it a low contractility because of the high afterload or because of a real low contractility? Another, actually this study shows that the peak aortic acceleration is more correlated to the NIHA functional classes in heart failure patients more than the ejection fraction. So this is very interesting. Actually, this was one of the cases I attended, showed that the index of contractility or peak aortic acceleration, it was a lifesaver. This case was a liver transplant, and he was a young, not young, 56 years old male.
Young.
Yeah, still, yes. 70 gram, 175 centimeters. Cirrhotic patient. Severe hyperfibrinolysis, as we can see. This is a peg, and you can see the clot breaks. That's why he was severely bleeding. It was a severe bleeding case. And they start managing him with a lot of blood products and tranexamic acid, yes. But then, when we connected our device, this was a hemodynamic profile. You can see, this is how the device looks like. So you can see here, this is the normal range. And these are the parameters. So stroke volume is in normal range. Cardiac index is high. And this is common in cirrhotic patient. Because in cirrhotic patient, because of vasodilatation, systemic vascular resistance is low and compensatory cardiac index is high. Okay? Index of contractility, the peak aortic acceleration at this time, at the beginning, it was in the normal range. And this is very nice. Everything moving fine because of cirrhosis, thoracic fluid or the extravascular volume is very high. That's why it's here. Thoracic fluid, it's not only a pulmonary edema indicator. It's not only a pulmonary edema indicator. It looks to all compartments. It's very sensitive, but not specific. So that's why TFC was very high. Stroke volume variation is 13, so no need to give him fluid. Once they start opening, collaterals was everywhere, a lot of bleeding, massive bleeding start. At this time, we will see what happened. This is later. The same, almost, cardiac index. Thoracic fluid didn't change. Stroke volume variation, they gave some fluid, so it goes down. So it became 9 instead of 13. Systemic vascular resistance is still low, the same. But cardiac index of contractility is the only parameter went down to 32. It was 45. And the blood pressure remained the same. So the contractility was depressed. And then we start debating with the doctors. Contractility went down. The blood pressure is maintained. But something happened with the contractility. We have to see what to give. But they didn't give anything, and they claim this is maybe because of the high bleeding.
Maybe because of the brace pump.
Stroke volume variation is 9. So it's not a volume issue from my point of view.
Pump issue.
Yeah, it's a pump issue.
Yeah.
Yes. It's a pump issue. Yes.
Beta 1.
But then, after 2 hours, contractility went even down. So it became 29.5. At this time, I called the head of anesthesia department. I told him everything is fine. The blood pressure, cardiac index, systemic vascular resistance, thoracic fluid, everything is the same as we start, but contractility is going down. So his decision was to prepare Doptex.
No, norepinephrine.
They already infusing norepinephrine. But he said, I'll give additional Doptex if his blood pressure went down.
Yeah.
After 2 hours, contractility index, but then it was a panic, I couldn't take a picture. Contractility index became 18. At this time, his blood pressure went to 60/30. And he infused the Doptex.
Beta 1.
Yes. So this was a very nice case showing that icon in a long operation with high bleeding, it can really differentiate. Is it a pump problem or it's a volume? It can help you.
You can predict even before time. We will know.
Yes.
This is happening.
Once you take the experience with the device, now they do it like this. Once they found the trend of index of contractility going down, they stop the NOR and give Doptex.
Yes.
And then when the index of contractility is returned, they switch to NOR again.
What dose the NOR was given there?
Norepinephrine, they used to give it continuous the whole liver transplant in case of cirrhotic patient.
Yeah.
In case of the autoimmune disease, they don't give. Because autoimmune disease, the hemodynamic profile looks like a normal patient. There is no cirrhosis, so there is no vasodilation, no need for giving NOR. So the doctor, the head of the department said, I can really help at the decision to stop norepinephrine. Actually, he published this case scenario. The last parameters that we measure, we look to the ECG. We don't look to the bioimpedance anymore in this parameter. And we do the heart rate variability and heart rate complexity. So we measure the variation in RR interval. And then we plot. Studies said that in normal patient or low risk patient, the variation should be high. So this timing should not be consistent.
Yeah.
When we found that the time became consistent, so the variation is very low, at this time the patient may develop shock. And this was proven by this study. We have some studies, and even more in the pipeline, but this study, they took all the victims from the bombing happened in the Boston Marathon 3 years ago. They went all to Massachusetts General Hospital, emergency department, and then they measured the heart rate variability and heart rate complexity. We call it sample entropy using our technology. And they found that all the patients with a low heart rate variability and heart rate complexity or sample entropy, they develop shock. So it can predict shock. So heart rate variability and complexity now, because actually it's a classic parameter, it's not a new parameter. Heart rate variability, they use it since early 90s. Philips is a first company, did it on their 12-lead ECG, but we are the first company to adopt it in a beat-to-beat monitor. But Philips, when they use it, the patient go to a session for 1 hour, to calculate heart rate variability and heart rate or sample entropy. And they use it to measure the patients with depression to monitor their therapy effect, such uses. But now this is the first time to adopt it in a beat-to-beat monitor. That's why we start using in ICU and OR. Another study showed that it says that real-time heart rate entropy, which is heart rate complexity, predicts the need of life-saving intervention in trauma activation patients. So it can really help predicting the need of more care. One study done in Egypt, they used heart rate variability, and it was published in the European Critical Care, heart rate variability to predict mortality in pediatric septic patients. So it can indicate the severity of the sepsis. Another study could predict sepsis very early when the heart rate variability is low. And in this study, they say the cutoff value for heart rate variability predicting mortality was less than 12.5. In normal patient, it should be 22. If it's less, it can indicate shock. But more or less than 12.5, it can indicate, if the patient is septic, it can indicate mortality or predict mortality. So what are the parameters that we measure? Heart rate, contractility indicator, peak aortic acceleration, the one we discussed, thoracic fluid, total fluid in the chest. It's not only intrapulmonary, everything, intraalveolar, corrected flow time. We can use it instead of stroke volume variation if the patient is spontaneously breathing. So we can use it. Pre-ejection period is isovolumetric contraction time. Then we calculate stroke volume, area under the curve, cardiac output, systemic vascular resistance, after all, and then stroke volume variation for fluid responsiveness. And we calculate even the oxygen delivery. I want to show you one picture. Shows that this is a kidney transplantation. And you can see here both the device and the monitor together. I want to show you that CVB compared to stroke volume variation, it's irrelevant at all. At the beginning of the case, before removing the kidney, systemic vascular resistance was high. Stroke volume variation was 7, so no need for volume. But CVB was 12. So we didn't give fluid. But then, But then, after removing the kidney, systemic vascular resistance went down. Okay. Stroke volume variation, he gave a lot of volume to fill the open vessels. So stroke volume variation became 5, CVB 12. Another one? Okay. Some doctors like to see the lab results to see, but then CVB 10, stroke volume variation is 4. Still no need to volume, but this one went down. Again 10, but stroke volume variation became 11. So the patient start to need again some volume. So this is an example shows that stroke volume variation and CVB is not really matching, especially when there is a change in hemodynamics like vasodilatation and then vasoconstriction because of giving no. We use 4 special type electrodes, so it's not a common ECG. Special type. We connect 2 to the neck, left or right. Actually, we recommend the right, so it can measure really the thoracic fluid at the right and left lungs together. So this position is better. So we place 2 to the neck, and the C electrode, it's very important. It should be at the xiphoid process level. Even in neonates, we put it on the xiphoid process level, because if it's gone down, it will include the abdominal fluids. If it went up, it will underestimate thoracic fluid. We don't need this. So C electrode position is very important. And then the D is flexible. It can go to the side, down to the side. So these are the 4 electrodes that we place. Special type, special position, not like the ECG. And it can remain on the patient for a long time, so you can use it for the whole operation. And even before and even after. So in terms of validation, is it valid to use our device? We have many validation studies in OR and in ICU and post-cardiac surgery. So everything, we have a lot of studies, and we can give you all the studies so you can look at it and see. It's not relevant to your department, but this is an experience in a hospital, a big children's hospital in Boston. In the first 402 pediatric patients. And the weight range enrolled in the study, 402, it was 1 to 107 kilograms. Look to this finding. This was a hernia repair case. So straightforward, no problem at all. 2-month-old, 4 kilogram female. During caudal injection, the timestamp was 3:20, and the cardiac index was 1.9. So the doctor decided to infuse epinephrine. After 6 minutes, cardiac index became 3.5. So actually, this study was to assess the need of hemodynamic monitoring even in the straightforward cases. And their conclusion that electrical cardiometry can give information, real-time information regarding developing hemodynamic events. And this is very important. The consumable is not expensive compared to all the competitors, and you can have all these parameters to aid your decision. Why not to assess the patient and see? Maybe unfortunate event can happen. And this was a message from this study. Also, we did another study even on the measuring the cardiac output in low birth weight and very low birth weight patients was a challenge. So we compared to thoracic, and there was a high correlation. In terms of application, we can use the device in many things, but they all share that we want to detect or early predict the pathophysiology. Pathophysiology of hypovolemia, it looks like this. Stroke volume is low, filling pressure is low, corrective flow time will be low from our device. Stroke volume variation, if the patient is mechanically ventilated, will be high. Systemic vascular resistance compensatory will be high. But then let us see this. This was a technical review done by the British Journal of Anesthesia, assessing all the technologies or all the parameters used to be used for assessing the fluid responsiveness. Okay, and they did the ROC curve, which is sensitivity versus specificity, to assess the power of prediction for each parameter. And they said that CVB, wedge pressure, IVC diameter, and corrected flow time, all these parameters, the power of prediction is 50 to 60% off. While stroke volume variation, pulse pressure variation, and Bliss Variability Index, their power of prediction was 70 to 80%. Maybe that's why when I show you the mapping between CVB and stroke volume variation, it was not coping together. And the British journal, they agree. Actually, they say that CVB power of prediction is 50 to 60%, except at the extreme cases, like zero CVB, very high CVB. It's very important to monitor CVB. I don't say stop monitoring CVB. But power of prediction for fluid responsiveness. If the patient will benefit from the fluid, not assessing preload. And then the gold standard, according to the technical review, with a power of prediction more than 90%, was the passive leg raising in ICU and the mini or rapid fluid challenge in OR. So you give the patient fluid challenge and see the change in stroke volume. So you need a cardiac output or a hemodynamic monitor. So the patient is in position A on Frank-Starling curve. He needs volume. When you give him a rapid fluid challenge, you will increase the preload. So on the Frank-Starling curve, he will here. Stroke volume, if it's increased by more than 10%, the patient, no need for volume. If the patient is already in B position, and you give him the same amount of volume, stroke volume will not increase by more than 10%. That's why you will not give him volume. So these were the gold standard according to the British Journal of Anesthesia. So assessing fluid responsiveness, the gold standard is rapid fluid challenge and monitoring the change in stroke volume, according to this technical review. Stroke volume variation also can be used, but it has some limitation. Maybe that's why, and pulse pressure variation, that's why the power of prediction is less than the mini fluid challenge. And mini fluid challenge can be used in spontaneously breathing or mechanically ventilated. Patient with arrhythmia and patient without arrhythmia. So mini fluid challenge is a really interesting technique to assess fluid responsiveness. Stroke volume variation and pulse pressure variation, all we take a window of cardiac cycles and we measure the minimum and maximum and see the change. If the patient is in position A, stroke volume variation will be higher than 13%. If the patient is here, the stroke volume variation and pulse pressure variation should be lower than 13%. So can we use it even in neonates? Stroke volume variation, I mean. 90 patients, it was in Paris Children's Hospital, 90 patients with average 6.4 kilogram, 6.5 months. And we can still use stroke volume variation. Responders group was around 19.4 and the non-responder was around 13. So higher than 13 should be used as an indication of, and even you can see the ROC curve. Unfortunately, it's not clear, but it's here, this one. So it's a very high ROC value.
5 دقائق.
5 دقائق. طيب خلاص. Okay, I'll go to this very fast. This is how the sepsis looks like. Actually, it was a case presented to ER, 60-year-old male, 90 kilogram, 170 centimeter, 100/50, feverage, heart rate 116, no urine for 1 day. When we connected our device and we said, this is how the device looks like, this is a normal range. So you can see cardiac output is very high, hyperdynamic state with systemic vascular resistance very low. And thoracic fluid is very high because of maybe microcapillary leakage. This indicates the patient is 95% sepsis. So you can start the protocol, validate by a culture, and start. A warm sepsis. I'll go also to another. This was a cold sepsis, and we see it in a pediatric patient. 1 week old baby, positive culture for sepsis. It was the third culture due to abdominal abscess, dopamine for 1 week. And when we connected our device, because of dopamine, systemic vascular resistance became very high, extremely high. 16,000. This is not normal. And cardiac index was low, stroke index was low, and it's sepsis case. So it's not a hyperdynamic state with vasodilatation. This is called sepsis. And thoracic fluid was not so high because of the vasodilatation, no capillary leakage. But then they start, based on the device, they switch from dopamine to dobutamine or dobutrix. Because and actually the patient survived. I'll give you, this is very important, the effect of ultrafiltration. This patient is 35 male, chronic renal failure, post-arrest, pulmonary edema. You can see in pulmonary edema patient, thoracic fluid is not like a high normal like the others. It's 98. The normal range is till 35. It's a very high thoracic fluid because of pulmonary edema. So pulmonary edema can increase the TFC very high, to a very high limit. In this case, the patient already has chronic renal failure, but his systemic vascular resistance was high, and his stroke volume variation, corrective flow time, because he's spontaneously breathing, I cannot rely on this. So 330. 330 means that no need for volume. If he's so. This case was presented by one doctor from Indonesia in the Asian Society of Anesthesiology, and he said, intensive care, he said that cardiac index, this patient, he want to monitor the effect of slow hemofiltration for 8 hours. So cardiac index was 1.7, systemic vascular resistance was very high, 3,000, and index of contractility was very low. After 8 hours of hemofiltration, you can see a totally different hemodynamic profile. 3.1, so much better. Index of contractility became normal. So he said that slow hemofiltration effect like an inotropic support and a vasodilator. So regarding the case, the decision was to do slow hemofiltration. However, this patient just finished the dialysis session, but he said that we will do slow hemofiltration. If hypertension persists, we will apply the myoclinic protocol. Okay, this is how the nephrotic syndrome looks like, because there is the protein is very low, so the osmolarity is very low. That's why extravascular is very high. And this is very nice to see the effect of different situation on the hemodynamic profile. The end message, I will go directly to there. Our device can be used in ambulance even, and helicopter evacuation, like in Paris Children's Hospital and so. But the end message is why to take part of the picture while we can have things to aid your vision. Thank you very much for your time, and I hope it was a nice presentation. Thank you. Any question? I'll be happy to answer.
What about the pleural effusion?
Pleural effusion, sure, it will affect our device.
It's unknown.
Sorry?
It's unknown, not diagnosed.
Thoracic fluid will be higher, okay, but we are not specific. So you have to diagnose why thoracic fluid is high. Actually, one of the cases that it's very new to us to use the device in the monitoring of during labor. So patients, we just released one study presented in Nature magazine, so it's a good study. And this study actually was assessing using thoracic fluid in a female with the preeclampsia, just before labor. And they can predict the need of oxygen therapy after the after labor.
The most important question is the price.
Yes.
How much? Because we want to buy this. So it's very good. Very good.
We are confident with our technology and our evidence.
It was a very nice
The
presentation
last study
for cardiac monitoring.
in open chest patient. So it's very hard for us because we rely on the chest impedance to change. It was 98%.